Okay, we'll lower it. Thank you.
Dr. Huawei P20 Pro, would you please tell me your name? There is a candidate joining with a mobile Huawei P20 Pro. Can you please identify yourself? Is it Dr. May? Okay, so we will start now. So this will be the second lecture of optics. I'm just giving you a quick reminder for the game's rules for those who are joining us for the first time. This will be, you are now opening the Kahoot.it from your mobile and enter the game PIN and your name. You will have to open the Zoom link from your laptop or any other device. There will be some questions presented in front of you. You will respond to these questions by choosing the appropriate color code from of the right answer. Then there will be score, and this score will depend on two main things: the speed of the answer and also the accuracy. But the accuracy is more important. So if they have two candidates have the same number of right answers, then the more rapid one will be the highest scorer. The top three winners will receive special gifts in the form of discount coupons that will be used in the future courses, and with terms and conditions apply. Prizes are not transferable and only single prize per winner is allowed per course. So let's get started with question number 21 of the optics exam. And here we go. Okay, that's correct. You almost all of you got it right. So let's. This question has been repeated in the previous exams, but with some different options and different question stem. So let's explain this question. Now, regarding the lasers used in ophthalmic practice, which one of the following statements is most likely to be true? Diode laser light is absorbed by melanin and hemoglobin. This is not true, as the diode laser is absorbed only by the melanin. And then the medium used in excimer laser is helium neon. No, this is not correct, as the medium used for excimer laser is the argon fluorine. Argon fluorine. The unaltered output of the ND-YAG laser is invisible to human eye. Yes, this is correct. And finally, the dansophil at the macula absorbs the green light, causing direct damage. You know, the xanthophyll pigments present at the macula are strongly absorbed the blue light. That's what makes the green light more safe. So let me ask you a question. All of you do YAG laser capsulotomy and iridotomy, and we can see that there is some red light in which is at the site of opening of the capsule or the iris. So what is this kind of laser, or what is the kind of this beam? You can see it is red. It is not invisible. So can you tell me in the chat box? Yes, exactly, Dr. Sendo. It is the Helium neon. That's correct. So that's what makes the answer C might be confusing for some, but the kind of laser that is used for the aiming beam is not the ND-YAG laser, but it is just as Dr. Sendo said, it is the helium neon. So let's see who got the right answer. Dr. Alia on the first place, followed by Dr. Roxana, followed by Dr. Nahal, Dr. Sendo, and finally Dr. Hagar, but the differences is very minimal. So let's see the explanations. As we mentioned that the diode laser emits a wavelength in the infrared range of 810 nanometer in the continuous wave mode. And this diode laser is generated by a semiconductor diode chip. And the diode laser are efficient and generate little excess heat and are portable. That's what makes them more preferable for macular treatment. And also the other advantage is that it's absorbed only by the melanin, not by the xanthophyll pigments, making them more safe for retinal photocoagulation. We have three types of ocular pigments. The hemoglobin present in the RBCs and in the blood vessels absorb the argon green laser and the krypton yellow. So it will causing the denaturation and causing coagulation of the blood vessels. That's why the argon laser and the krypton yellow are used for photocoagulation. The xanthophyll pigments present in the macula has its maximum absorption of blue spectrum, so that the argon blue is not recommended for treatment of macular lesion. It will cause much more destruction. So the green laser or the green light is better for the macula. Then the melanin is present in the RP and the choroid. It absorbs the argon and absorbs also the krypton and also absorbs the diode laser, and it can be used for pan-retinal photocoagulation and destruction of retinal pigment epithelium. The excimer laser has the medium of the excimer laser is the argon fluoride, not the helium neon. And as we mentioned, the helium neon laser is the laser which is used for the aiming beam of the Nd:YAG laser. So the helium neon is a low power gas laser which has its color is visible. It is red as its wavelength. It is 632. And it is used for aiming beam with lasers with invisible output, such as for Nd:YAG laser. So this is for this question. Okay, next question. Okay, so here we got a wrong answer. So regarding the stereopsis, which one of the following statements is most likely to be true? So can you tell me what will be the normal stereo acuity? Tell me in the chat box. What will be the normal stereo acuity? Yes, exactly. And what will be the stereo acuity that show that the person is more likely to have amblyopia? Exactly, I agree. It is 250 or worse. So 250, this is the starting point of having amblyopia, but this is not a significant amblyopia. Here is the trick about this question. A significant amblyopia meaning that it is like in thousands, but 2050, this is just makes the starting point for developing amblyopia or make you consider that this patient could have amblyopia. So this is for this option, why it is the right answer. Why the second couldn't be the right answer? We mentioned in the binocular vision lesson that stereopsis is not only present within the Panams area. Can you tell me where else the stereopsis could be? Is stereopsis is exclusive in the Panams area? So where else could it be? So when we mention the zones of vision or binocular vision, we mentioned that we have first the horopter, then followed by the, no, it's not in the horopter, as the horopter will not stimulate stimulate non-corresponding retinal points. So we have the horopter, then the panams, then the area outside the panams area. And we mentioned that the stereopsis occurs in the panams area and in area outside the panams. So please be careful of the using the words. It's asking in this question about stereopsis can occur only if the two images are within the panams area. They can occur if the images are present within the panams area, but also they can occur if the images are present outside the panams area, which will result in physiological diplopia, but still with stereopsis. But please note that stereo acuity is measured within the panams area. But the question here is not asking about measuring the stereopsis, but asking as a broad statement about stereopsis. Could it happen only within the panam area or not? No, it could happen within the panams area and also in the area outside the panams. As you all mentioned, that the normal stereo act is about 60 seconds of arc only, not 800. And vertical disparity will not produce good stereopsis because vertical disparity can cause more diplopia, and the brain will not be accustomed to fuse images that have vertical disparity and produce stereopsis. Will be more troublesome for the brain, but stereopsis is based on the horizontal disparity. So let's see who got right. Nobody got the right answer, but let me explain to you furthermore of this question. Starting, what is the stereo acuity? Stereo acuity is the ability to fuse slightly dissimilar images which stimulate the disparate retinal elements within the panams fusional area in the two eyes with the perception of depth. So when we are measuring the stereo acuity, we are measuring it in the panams fusional area. Okay? It is graded according to the horizontal disparity of the retinal image, and it is measured in seconds of arc. What is meant by seconds of arc? Let's assume that the both eyes are looking to this man and this tree, and they are separated from each other. So we want to appreciate the depth that the man is closer than the tree. So how does the eye assume that? The eye has an angle. This angle, like angle A, is between, it is the angle subtended by the tree, and the angle B, it is the angle subtended by the person, and the difference between both of them is called the angle C. This is called the angle of stereopsis. This is the angle which is expressed in the seconds of arc. So this the more narrow this angle, or the slight, or the more few this angle, the better the stereopsis. That's why we are saying that the less the number, or the normal stereopsis is 60. If it is less, it will be better. This patient or this man could have higher stereopsis. But if it is more, meaning that this angle is wide, meaning that this person cannot appreciate the depth perception well. And this means that he has a problem with the stereopsis. So the normal stereo acuity is about 60 seconds of arc or better, and the stereo acuity of better than 250 is said to exclude significant amblyopia, okay? And the stereo acuity worse than 250 may be an indicator of amblyopia. So please notice that if a patient has good stereo acuity, like about 60 or 70 or 100 or 200, then this is not a significant amblyopia. It is still not significant amblyopia. But if it is worse than 250, then it will be indicator of amblyopia, meaning that it will be the starting point. This patient could have amblyopia. He should be investigated for presence of amblyopia. But to have a significant amblyopia, then the stereo acuity could be 3,000, 4,000. So we cannot say that the 250 is indicative of significant amblyopia, or as the question is saying, that the 400 will be a significant amblyopia. Okay. So here is what we mentioned by presence of the stereo acuity within the panams of fusional area. When there is horizontally disparate images, then they fall on non-corresponding retinal points on the right and the left eye. That's how we can appreciate the depth perception. And the brain appreciate the horizontal disparity better than the vertical, because as you can see that the Panam's diffusional area is more wide than in the horizontal meridian than in the vertical meridian. It is narrow here, but it is wide there. So this wideness of the Panam diffusional area making the horizontal disparity appreciated more. But if there is objects are in the vertical or closely in the vertical meridian, or they are above or below each other, this will not produce good stereopsis. And we said before in the binocular vision, this example, when you see this a hand, it will not be very annoying to you because your brain can fuse the finger in that are horizontally displaced at a little bit, making them not very confusing, as this can stimulate non-corresponding retinal points in the horizontal plane at the Panam's diffusional area. But when you look to this face, this picture will be very annoying because we are not able to do stereopsis or appreciate depth perception for the vertically displaced images or vertically displaced objects, as our vertical fusional versions is low. So this picture will not produce any good stereopsis. And here we also mentioned in the binocular vision that we have some characters of objects seen at the Panam's diffusional area. So they show retinal disparity, but they are still seen single with a stereopsis. But this is not only for the Panams, or the stereopsis is not exclusive for the Panams, but also can be for the area outside the Panams here. They still stimulate retinal disparate points, but produce physiological diplopia with stereopsis. This is very important. So then when the question is asking, how can we test stereo acuity? It is tested within the Panam's diffusional area. If the question is asking, if the stereopsis is only present within the Panam's area, no, it can be present within the Panam and outside the Panam. I hope that this is clear now. If you have any comment or you have anything to add, please let me know, or you can speak directly after opening the mic. Okay, so let's move to the next question. Exactly, so all of you got it right. Patient with high order aberration. Which one of the following is most likely to be true? So first of all, let's define what is the higher order aberration. Well, the higher order aberrations are like specific distortions within the vision. It is due to distortions of the ocular structures, like as the ocular structures are not well aligned, are not perfectly aligned to each other, and are not perfectly aberration free. So they can cause some distortion in the vision. And the curvature of the retina increase the curvature of the visual field. This is not true. This optical aberrations can occur with LASIK as well as the PRK, as both of them, the laser is directed on the same way in both conditions. They are just different ways for making the flap or to access the subepithelial or the stroma of the patient. But the laser is the same in both ways. So this laser or the excimer laser can induce higher order aberrations. So this is not true. And they are more commonly with those who have physiologically dilated pupil. That's why it is very important to inquire and to investigate for those who have scotopic dilatation, because these patients are more likely to have symptoms from these optical aberrations preoperative and even postoperative if they are scheduled for refractive surgery. And they can be diagnosed using the wavefront technology, and this is the correct answer. So there are devices called the aberrometers that are able to detect the higher order aberrations. So all of you got to try it. This is the order. Dr. Ali is still in the first, followed by Dr. Nahal and Dr. Roxana. So let's see the explanation. So we mentioned in the first lecture of optics that the pupil diameter is about 2.5 millimeter for a reason. This is because if it is less than that, it will the quality of light or the visual acuity will be less by diffraction. The light will undergo diffraction. It is the same as you put this water through this small pipe. The water will be dispersed around or outside this pipe because the aperture of the water is more than the aperture of the pipe. And this is, but so does this mean that we need a fully dilated pupil or higher dilatation of the pupil? No, because if it is more than 2.5 millimeters, the light which is going through the eye is more likely to be to suffer from chromatic and spherical aberrations caused by refraction from the lens periphery and the corneal periphery. So the fully dilated pupil or the physiologically dilated pupil will allow more aberrations, will allow more higher order aberrations. So these the higher order aberrations are can or the aberrations can be classified as a small order aberration or low order aberrations and the higher order aberrations. The low order aberrations like the astigmatism and myopia and hypermetropia, while the higher order, these are the aberrations that can be corrected by glasses. But the higher order aberrations are distortions in the visual system that cannot be corrected by the glasses, like the trefoil, like the coma, like the spherical aberrations. And these are what are responsible for this some visual phenomenon, like the patient's reports that he can see glare or see halos or star bursts. These star bursts or halos or glare are or occur due to the presence of higher order aberrations. Yes, Dr. Alia. So this can be managed by what's called the wavefront scan. Wavefront scan, this can be done by some devices which are called aberrometers. These aberrometers are can detect the amount of aberrations that this patient have, either low order or high order, and it can be used as a map for correction of these higher order aberrations through some devices called or through a technology called the wavefront guided ablation for the cornea. And this can be done by several devices that have this ability to read, to interpret the wavefront map of the eye and direct the laser according to this wavefront, so it will correct the higher order aberrations. Okay, so let's move to the next question. Okay, so I don't know why this question was very rapid. Maybe I just didn't adjust that timing. Okay, if we have a patient with relative spectacle magnification, which is most likely to be less than 1. So none of you answered it the first one, because a refractive hypermetrope wearing glasses at the back vertex distance of 12 millimeter, this is like a case of aphakia. And those patients who are wearing aphakic glasses or high plus lenses present at the spectacle plane, so these patients will have the relative spectacle magnification of 1.3. So this is not the true answer. A refractive myope wearing glasses at the anterior focal point, yes, this is the correct. Because the myopic patient, when he put the glasses further away, this will cause minifying effect, and as we mentioned yesterday, and then he should be corrected by contact lenses. And also there are some rules that we will discuss again today in order to make you understand how to address these kinds of questions and how to interpret who is going to have magnification and who is going to have magnification, depending on whether he is myope or hypermetrope, depending on whether he is corrected, whether he has axial or refractive ametropia. An axial hypermetrope wearing the glasses at the anterior focal point, no. Here the relative spectacle magnification will be 1 because he is axially hypermetrope. And we said, according to the NAPS rule, that the axial hypermetropia or axial myopia, when corrected by glasses at the anterior focal point, which is about 15.6 millimeters, then the size of the retinal image will be the same as the size of the image with correction, or the size of the image will be the same as the emmetropic image size. Axial myopia with using a contact lens, no, those who have axial myopia and we are corrected by contact lens will not show decrease of the relative spectacle magnification, but they will show higher magnification. But so they will be more there will be less magnification than the glasses as they are axial according to the NAPS rule, and they are now approaching or they're moving their correction more toward their eye, so they will be more than the glasses. So let's see who got it right. Okay, Dr. Roxanne and Dr. Sindhu. So let's see the explanation. Now, in order not to get it wrong, I will give you what is called the golden rule. What is the golden rule? We have axial myopia and the axial hypermetropia, and refractive myopia and refractive hypermetropia. In case of axial myopia, as we mentioned in the NAPS rule, if the correcting lens is placed at the anterior focal point of the eye, then the image size is the same as emmetropia. So I guess we all agree about that, as the relative spectacle magnification will be equal 1. So we mentioned that yesterday. But what we want to add today is in case of refractive. If the patient has refractive myopia or refractive hypermetropia, then if the correcting lens is placed at the principal point of the eye, then the image size will be the same as emmetropia, or the relative spectacle magnification equals 1. And the more we are away from the focal point of the eye, anterior focal point of the eye, or the more we are away from the principal point of the eye in case of refractive myopia, the more the effective power will change, either by increase or by decrease. So when we are saying about magnification, relative spectacle magnification, it is the same way when we are talking about the effective power of the lens. So both are the same. If we are talking about the magnification will increase, this means that the effective power will increase. If the magnification is decreasing, then the effective power of the eye is decreasing. So let's now see the next slides will enlighten you more about these kinds of questions. Here is the eye, and here is the anterior focal point, which is about 15.6 millimeter according to the schematic eye. And this is the spectacle plane, which is around 13 millimeter, and from the anterior surface of the cornea. And this is the principal point according to the schematic eye, and this is like 2 millimeters behind the anterior surface of the cornea. Okay, so if we have axial ametropia, or if we have axial myopia or axial hypermetropia, according to the NAPS rule, if we put the plus lens or the minus lens at the anterior focal point, then the relative spectacle magnifications equals 1 here and here. Okay, so the size of the retinal image will be the same as the emmetropic image size. But what happens if we move the lens forward or backward? If the plus lens, we are moving the lens forward, then the relative spectacle magnification will be less than 1. So in order to sorry, the relative spectral magnification will be more than one. That's why the hypermetrope tended to push his glasses down his nose in order to gain magnifying effect. The reverse will happen when the glasses is substituted by the contact lens, as the relative spectral magnification will be less than one. So when we put a contact lens, we need to increase its power. The reverse will happen with the minus lens. If the minus lens is present at the anterior focal point, then the relative spectral magnification will be 1. If they are pushed further away from the eye, then there will cause minification, or the image will be smaller, as the relative spectral magnification will be less than 1. But if we push the glasses toward the eye, then the relative spectral magnification is more than 1, so this will result in more magnification, or the lens is said to be have more effective power. So there is nothing new here. We mentioned all this yesterday, but let's now see what will happen if there is a refractive ametropia. If there is refractive ametropia, the theory says that if they are present, or if the lens plus lens or the minus lens present at the 2 millimeter behind the anterior surface of the cornea, then the relative spectral magnification will equal 1. And if we are moving away, from the, if we are moving away, then the relative spectral magnification will change. Just hold on for a second, please. Just hold on, please. Okay, sorry, I'm back. Let me share you my screen. Okay, so what we mentioned is that in the case of refractive myopia, this depends on that The lenses present at the principal point or the principal plane will be the same size of the immetropic retinal image size. But if we are further away, then the retinal image size will be different. How is that? If we are getting further away from the principal plane, if the plus lens or hyperopic refractive hyperopia, then if the correcting lens is where in the spectacle plane, then the relative spectacle magnification will increase, will be more than 1. And if we move further toward the anterior focal point plane or anterior focal point, the relative spectacle magnification will further increase. Let me just annotate. So the more we get away from the principal plane, the more magnification we get for cases of plus lenses. This is for refractive hyperopia, okay, for hypermetropia. But what happens with the minus lens or the refractive myopia? It is the reverse, meaning that the relative spectacle magnification, if the lens is placed at the principal point or the principal plane, it is 1. And the more we get away from the eye, or the more that we get away from the principal plane, the more magnification of the lens. So relative spectacle magnification of the lens present at the spectacle plane will be less than 1. And lens present in the anterior focal plane, again, it will be even magnified or more smaller. And this is what was asked in the exam. It is if a present of a minus lens present at the anterior focal plane of a refractive myopia. So who will be have most likely to have less than 1? It will be a refractive myope who have glasses wearing at the anterior focal point, like this. So let me show you the question again, so that you now got the answer. So refractive hypermetropia wearing glasses with a back vertex distance of 20 millimeter will have higher magnification because he have hypermetropia. So this is like a phakic glasses, and will have about 1.3 magnification. Refractive myopia wearing the glasses at the anterior focal point, as we mentioned, since it is away, he is refractive, so you count from the principal plane, and it is away from the eye at the anterior focal point, so it will undergo more magnification, and the relative spectacle magnification will be less than 1. An axial hypermetropia wearing glasses at the anterior focal plane will have relative spectacle magnification of 1. Axial myopia using a contact lens, it will have less magnification than the spectacle, so it should have be not it can be slightly less than 1, but the refractive myopia wearing glasses at the anterior focal point will be far beyond the 1 or far below the 1. So I hope that this is clear now. If you have any question, please let me know. Okay, so I guess that we don't have any questions, and let's continue the game. Yes, exactly. Most of you got it right. So regarding the diffraction, which one of the following statements is most likely to be true? It increases the light intensity due to constructive interference. No, this is not correct. The light will not show increase in intensity, but even it will be dispersed over larger areas, so it will be less intense and will be less sharp, as I will show you now. It is one of the reasons for reduced vision when the pupil is dilated. No, it will be the reason for reduced vision when the pupil is small. It is reflected scatter of light on meeting an obstruction. No, it will be when it is meeting obstruction, it will undergo bending of light. So it is bending of the light on meeting an obstruction, no reflection here. It is used in the design of multifocal lenses. This is correct answer. This is one of the two mechanisms for construction of multifocal lenses. They can be either diffractive or refractive, and this diffraction, which is responsible for making the contact lens see the lens see for near. This diffraction is what's responsible for making the lens, the IOL or the contact lens, be able to see the near vision. So let's see who got it right. Almost all of you got it right. With now Dr. Sendo is coming in the third place. And let's see the explanations. So as we mentioned before that when the wavefront of light is meeting an obstruction or a hole in obstruction, then at the edge of the obstruction, this will result in bending of light, causing these waves. These waves are secondary waves from that appear to come from this aperture or this opening. So there is no reflection here. And as a matter of fact, if the light is propagating in parallel waves with no obstruction, however, it should be like this, but actually this doesn't appear. But when it is meeting an edge of obstruction, it will continue as waves. These waves can make this disk, which is called the iris disk, has alternating dark and white bands, and this will cause that the light intensity will not be that sharp. Okay, as we mentioned that the pupil is small, which is when the pupil is small, this will result in diffraction, which will cause decreased visual acuity. And the diffractive intraocular lenses are based on the principle of diffraction. So the surface or the back surface of the lens will have diffractive surface, and this diffractive surface making these steps will cause a secondary image. This secondary image is the one which is responsible for the effective add power, making the IOL or making the contact lens be able to see the near. So it can see the near and it can see the far. And this is used for the design of the multifocal intraocular lenses. Okay, so let's move to the next question. Okay, so we have very confusing options here, really. So regarding the total internal reflection, which one of the following is true? Light source during vitrectomy can be considered as an example for the total internal reflection, as the light will pass into fiber optics until they reach the probe that enter the eye and can illuminate the retina. So this can be considered the right answer. But also the viewing the retina with indirect ophthalmoscope, this can be also considered a right answer, because during the construction of the indirect ophthalmoscope, there is a right angled prism which is responsible for the binocularity or responsible for the like shifting of the light from the patient's eye to the observer's eye. So I just want to ask you why those who are mentioning a light source during vitrectomy are not convinced with the viewing the retina of indirect ophthalmoscope, and also those who are answering viewing the retina of indirect ophthalmoscope, did you read anything that the light source during vitrectomy is not correct? Because in my opinion, both answers are right. No answers? Okay, so let's us review the right answers. So we mentioned that one of the prisms that are used or utilize the principle of total internal reflection will be the right-angled prism. So the right-angled prism can shift the light rays for 90 degrees. And as we mentioned before in direct ophthalmoscopy lecture, when the light is reflected from the patient's eye, it will undergo convergence by the condensing lens. Then it will now should enter the observer eye. But the observer eye are separated by the interpupillary distance. So how can they reach the eye? This is by the pupillary distance reduction system. First of all, the light will hit mirrors. These two mirrors they will be reflected to right-angled prism. So here is a right-angled prism, which is responsible for shifting the light 90 degrees by total internal reflection in order to enter the eye. So as you can see here, then the light coming from the condensing lens hitting the mirrors on both sides, then the light will strike the right angle, the prism, and undergo total internal reflection to enter through the plus lenses, which is used to relieve the accommodation. For my opinion, yes, I guess that both A and D are true. I don't find a reason why anyone would be wrong. So as I searched for many resources, yes, both are true. Okay, so let me also, I tell you my perspective for this question, as I also feel it is very tricky question. Which one of these purposes is the stenopic slit is best used? To assess the macular function in the presence of cataract, we agreed that this is not the use of stenopic slit, as the stenopic slit is used to identify the acts of astigmatism and the power of astigmatism. So this is not the true answer. To reduce optical aberrations in high-powered lenses, again, this is not the true. This is not the value of stenopic slit. So here we come to two confusing answers. To detect the high level of astigmatism in the poorly sighted patients or to measure the visual acuity if a pinhole cannot be used. I will tell you why I believe that C is the correct answer, not B. So why we are using what is the simple definition of a stenopic slit? The simple definition of a stenopic slit is that it is elongated pinhole, meaning that if you are using a pinhole to detect the patient with potential visual acuity, the stenopic slit can do the same, but for the astigmatic patient. But what happens if we have a poorly sighted patient? Please just concentrate on how the words are present to you. To detect the high levels of astigmatism in a poorly sighted patient, the poorly sighted patient can have a problem with his vision refraction, like he have high astigmatism, as the question is mentioning, and also he could have a coexisting pathology, like if he has cataract, has age-related macular degeneration. So what happens when you are using a stenopic slit on these patients who have poor sighted vision from either high level of astigmatism or any other reason? Can the stenopic slit differentiate whether the poor vision is due to high level of astigmatism or any other reason, as the question is asking? So the question is asking, it is used to detect a high level of astigmatism in the poorly sighted patients. But for those patients, this will not be the appropriate method because those patients could have poor sight from other reason. But actually, it can be used to detect a high level of astigmatism in good sighted patient. Like if the patient has good vision and with his refraction, like he is not amblyop or doesn't have any coexistent pathology, and you are now putting the stenopic slit in front of his eye, and you can found that his vision is attributed to the refractive error only, not for any other reason. But for if the patient has other pathology or other disease, then the stenopic slit will not be useful. But it is used to measure the visual acuity. If pinhole cannot be used, this is the correct answer. As I told you, it is the idea of the pinhole is to create a clear retinal image irrespective of the refractive state of the eye. So this goes with the pinhole or with the elongated pinhole, which is the stenopic slit. So if we say that the stenopic slit is like an elongated pinhole of about 1.2 to 2 millimeters, this can determine the refraction and the principal axis of astigmatism. And we can know by it the potential visual acuity of this patient using the stenopic slit. So just to think that the stenopic slit, it is like a pinhole. If we said that it is a pinhole, you will find simply that the C is the right answer, as we use the pinhole to know the potential visual acuity of a patient. Okay, so I know that some of you may not agree with this, but this is open for discussion, so we can have a discussion about this, and this is my point of view. So this is the stenopic slit. It is used for determination of the axis and the principal axis and the refractive power of the eye. So as I told you, it acts as elongated pinhole. This is very important, and they allow only the light of a certain axis to enter the eye. Hence, when the slit lies in the principal axis of the astigmatic eye, the second line become in focus, or the second line focus is eliminated, and the blur of conoidosturm is reduced so that the patient can appreciate a clear image, and we can measure the visual acuity with this. So as I'm telling you, it is consider it like a pinhole, and you will find that this is the correct answer. So let's get back to measure visual acuity. If a pinhole cannot be used, yes, a pinhole cannot be used, or it can be used for astigmatism. But since the question is telling you that pinhole is not available, or it cannot be used, or it is not very useful, and does the stenopic slit can be used for measuring the visual acuity in this case? Yes, it can be, because it will eliminate the blur of conoid of Sturm and allow the light in the principal meridian to only enter to the eye. Please, if you have any comment, or if you wanted to ask about something, let me know in the chat box or through the mic. So my theory, or my understanding for this question, that they are using to detect high levels of astigmatism in poorly sighted patients for a reason. They can simply just say they can detect astigmatism, or they can detect astigmatism in a normal patient, which is true. But why they are specifically asking about high level of astigmatism in poor sighted patients? This is because these poor sighted patients, they didn't mention that this poor sightness is due to the astigmatism. And if this is the case, then the stenopic slit will not be able to differentiate between both reasons, either due to high level of astigmatism or due to other coexisting pathology. Okay, so thank you, Dr. Hagar. And let's now move to the next question. So I think that all of you say, thanks God, finally some question that we know or some question that is repeated. So let's review this question which appeared before in the exams and explain it. I think that I explained it before in the WhatsApp group. So in high myopia of -10 diopters, when we are changing to contact lens from spectacles, this will result in which one of the following? Well, is the peripheral optical aberration will be increased? No, as the peripheral optical aberrations will be decreased as there is no prismatic effect of the lens periphery. So no optical aberrations. Symptoms of presbyopia become more evident? No, we said before that symptoms of presbyopia will become less evident due to magnification, as the glasses will cause more small image, while contact lens will produce more larger image. If we are putting the contact lens over the eye, then it will produce more magnification, leading to that since the image is more magnified, it will stimulate more photoreceptors, causing the presbyope to become less complaining, as the complaint of presbyopia occurs from more recession of the near point. So the patients need higher aid or higher plus aid in order to see well or to see the image magnified. But since the contact lens will produce more magnified image than the glasses, then the contact lens will be better and the symptoms of presbyopia will become less evident. And the third, the field of vision will be smaller. This is the correct answer. So we mentioned that the myopic glasses, the high myopic glasses can cause image distortion. The prismatic effect of the lens periphery can cause a enlargement of the visual field, and hence when the patient is shifting from glasses to contact lens, this will result in that the visual field becomes smaller. And finally, the retinal image will be smaller. This is not true. The retinal image will be larger. And you can see that the option D is wrong, and option D confirm that option B is wrong, as the retinal image will be larger. So if the retinal image will be larger, then the symptoms of presbyopia will become less evident. You got it? That those who have presbyopia will be less complaining because they have larger retinal image size. So you can, the D and B and D are both are wrong and they are both confirm each other. Okay, so let's see who got it right. We're still keeping the same order with Dr. Alia in the first place, followed by Dr. Roxana and Dr. Sindo. And let's see the explanations. So we said before that the image distortion occurs at the periphery of the high powered lens. One of them is the pincushion effect caused by the high plus lens, while the barrel distortion caused by the high minus lens. And this will result in changing in the visual field, meaning that the pincushion effect will cause reduction of the visual field. This is caused by, as the prismatic effect will cause that shifting of the image toward the visual axis. But the opposite occurs with the myopic lenses, as the myopic lenses will cause shifting of the image toward to the periphery, causing enlargement of the visual field. And this will cause that when we are shifting to contact lens, the field of vision will become smaller. Okay, let's move to the next question. Finally, all of you got it right. So regarding the polar prism, which one of the following statements is most likely to be true? It deviates light through 90 degrees. No, it deviates the light through 180 degrees. It is used for image doubling in a keratometer. No, this is not the kind of prism that's used for doubling in the keratometer. Can you tell me the name of a prism used for doubling in keratometer? Yes, exactly, Dr. Nahal. It is Wollaston prism. Now, Wollaston prism can be used for the Javal-Schultz keratometer as a doubling device. So it is not the photoprism. Light is deviated by total internal reflection. This is correct. And the image is transposed left to right. So this is not true. Can anyone tell me an example for a prism that shifted the image from right to left or left to right? Exactly, Dr. Roxana. It is the Dove prism. So that's correct. So let's see who got the right answer. Dr. is still keeping the same order. And this is a very tough round. Let's see the explanation. So we mentioned before that the reflecting prisms, like a photoprism, they shift the image 180 degrees, and the image is inverted and laterally transposed, but not transposed from left to right, as it is the Dove prism which will cause transposition of the image from left to right or from right to left. On the other hand, the keratometers that use a prism, it is called the Javal-Schultz keratometer, in which the Wollaston prism is used. There are other keratometers, as you know, so let's just revise them. We have the von Jung-Helmholtz keratometer, which is used the two rotating glasses as a doubling device. On the other hand, the Bush and Lomb keratometer, it is used two prisms, two vertical prisms as doubling devices. Okay, let's move to the next question. Finally, it's an easy question. Exactly. So how to transpose +3 to +1 axis 90 to a negative cylinder? We add the sphere to the cylinder, so it will be +4. And with the reverse sign of the cylinder, it will be -1, and the perpendicular axis, it will be 180. So all of you got it right. And let's see who got right. So Dr. Hagar coming to the fourth place. Well done. And let's see the no explanations here. Just move to the next question. Exactly. So most of you got it right regarding the measurement of the back vertex distance using the trial frame, which will be the correct answer. So we have two methods to measure the back vertex distance. One is using the ruler method, and the other from the side of the trial frame, like as the question here is saying, which one? Yes, the side arm ruler of the trial frame can be used, or we can use a ruler that are measuring from the side or through a stenopic slit, as I am going to show you now. But the rule is that we always measure from the back cell. We always measure from the back cell, not from the front cell, not from the middle cell. It is always from the back cell, whether we are using the stenopic slit or we are using the side arm ruler of the trial frame. And also please note that it is not only necessary for myopic prescriptions more than 5 diopters, but it is also for myopic and hypermetropic, or simply for any more than plus 5 diopters. We should mention the back vertex distance, like more than plus 5 or minus 5. So only the first three are got it right, and let's see the explanations. So we mentioned before that we are measuring the back vertex distance. So this is the distance from the glasses to the anterior surface of the cornea. And this is important, especially when we are measuring high errors of refraction, like more than plus 5 or minus 5. If we see the compartments of the trial frame, we can see that there are 3 compartments in front, and when we are, and there will be 1 compartment behind. It will be this one, or this one, or this one. This is the first one. When we are, so most of the trial frame have 3 to 4 compartments. We put in the back cell that of a high powered lens. The most power or the high powered lens should be put in the back cell. This will be more optical. And also, so if the patient who are going to measure back vertex distance, we need to put this more than plus 5 or more than minus 5 diopters lens in the back cell. The other three, the second one will be for spherical lens, and the third or the middle will be for the cylindrical lens, and the fourth will be for any accessory lens or a prism or a pinhole. It can be made for the most anterior cell. So this is how we place the different lenses through the trial frame. So how to measure the back vertex distance? If we have a high powered lens over 5 diopters, it should be placed in the back cell of the trial frame, and the back vertex distance must be given within the prescription. The back vertex distance may be measured with a ruler that are held parallel to the arm of the trial frame, or if we can, another method is used to a small ruler which is slipped through a stenopic slit, which is placed in the back cell of the trial frame until it touches the closed eyelid. Then we add 2 millimeters for the thickness of this eyelid. So let me show you. Oops, sorry. This was just rapid. Okay, you will find it in the notes. Okay, I'm glad that most of you got it right, because this question can sometimes be difficult and confusing. And in order to eliminate the confusion and make it to have some strict rules in your mind to answer these kinds of questions, where they put you different refractions and asks you to choose which is one is the most problematic, or the most one that needs glasses, then you should have some certain rules. The first, you should note the age. You should, here we have fixed age. So luckily we don't have different ages, but we have a fixed age. So this will make our mission much more easy. Then the second variable will be the error of refraction. So we have, the patient could have myopia, hypermetropia, astigmatism. As you know, the most amblyogenic, then it will be the hypermetropia, followed by the astigmatism, followed by the myopia. So if we want to indicate the urgency of glasses, then the hypermetropia will be the first, followed by the astigmatism, as the astigmatism will cause amblyopia in only one meridian. And lastly will be the myopia, as the child can tolerate the myopia better because he doesn't usually look at the sky, but he just his surrounding environment is like the 2 or 3 meters around him, just for eating and playing and so ever. So the hypermetrop will carry the highest emergency or highest urgency for having glasses. Also, we need to know if this patient has strabismus or not, because this will also can give us a clue whether they need glasses, whether they have urgency for glasses or not. For example, those who have esotropia or accommodative esotropia, not esophoria. Those who have accommodative esotropia, they will need full glasses prescription or full cycloplegic refraction. But we don't have this option here. They just present you an esophoric child, and even this esophoric child has plano refraction, not even he has plus refraction. So this is not the case here. The third thing that we want to check for these kinds of question is there is an isometropia or isoametropia, meaning that does both eyes have the same refraction or the refraction is different, because an isometropia is will be more intolerant to a difference in refraction. So we can tolerate slightly larger errors of refraction if both eyes are the same. But if the both eyes are not the same, then this tolerance will be less. Then this may indicate the more urgency for prescription of glasses. So having these rules in your mind, let's now see the options. An esophoric child who is plano with minus 1.75 at the right and the left, well, see, this esophoria will not concern us here because he doesn't have an accommodative esotropia and he has plano refraction, so he doesn't have a hypermetropia, but he has astigmatism, which is similar in both eyes and minus 1.75. Well, at an age of 3 years old, this child may need glasses, but is this the highest urgency among all these options? Let's see. Orthophoric child, option B, orthophoric child who is 3 years old and has one diopter of sphere in both eyes, there is no problem at all. This child doesn't need glasses. He has minimal myopia, and this myopia will not cause any amblyopia at all at this age. As myopia should be like more than 2.5 or more, as long as he is isoametropic or both eyes are the same refraction. Orthophoric child who has right plus 2 and left plus 0.25, at this age, a plus 1.75, an isometropia between both eyes is amblyogenic and can be considered an indication for prescription of glasses as a matter of urgency, because as I told you, the child cannot tolerate hypermetropia better, but he can tolerate the myopia better. So let's see if this is minus 2 and minus 2, 0.25, there is no problem. But since it is on the plus side, then this is a problem. An orthophoric child who is right plano and plus 1 cylinder and left plus 0.5 and plus 1.5. So we here have an isometropia, but the difference is zero point 0.5 in the sphere and one diopter in the cylinder. And again, this is not considered amblyogenic and can be tolerated. So these figures, they have some rules. They are set by the American Society for Pediatric Ophthalmologists, and I'm going to present you the table so that you can know what are our cutoff values. These are the guidelines for refractive correction in infants and young children. This depends on the age, whether it is less than 1 year or 1 to less than 2 years, 2 to less than 3 years, or 3 to less than 4 years. And also it depends whether it is isoametropia, meaning that similar refraction in both eyes, or an isometropia. So in the first option, it will also depend on the kind of refractive error, whether it is myopia, hyperopia, or astigmatism, and whether hyperopia has manifest astigmatism, manifest deviation, or esotropia or not. These are the factors that will control our need or the child need for the glasses. So in the exam, they asked about a child who has minus 1.75 slender in both eyes. So here we have the child is 3 years and he has a slender of 1.75. So he can be considered a candidate for since he has an isometropia with astigmatism of minus 1.75 in both eyes. Yes, he considered isoametropia with cylinder of the same degree at both eyes. So this can be the number one indication unless we have an isometropia that needs the glasses more. The second option is asking about a child who has again isoametropia with minus one sphere in both eyes. So here is the myopia. The child of a 3-year-old can tolerate 2.5 diopters at both eyes. So this is not the right answer. The third option is an orthophoric child that has 2 diopter sphere and only 0.25 diopter of the other eye, so he has hyperopia with the difference between both eyes more than one, it is 1.75, and he has one eye which is 2 diopter. So one eye is more than 1.5 diopter and there is an isometropia. So this child has more urgency to wear glasses. So these are the guidelines. How can we prescribe glasses in children? And yes, the trick in this question, they present you 2 children that need glasses, but one is more urgent than the other. So that's why I'm telling you that there are some certain rules that you should know or you should follow in order to know who is the child who deserves the glasses most. Okay, so let's move now to the next question. Also, this question is tricky, so I hope that you can detect the trick. I'm happy that all of you got it right. So, which one of the following is most likely to cause a spectacle intolerance? First one, changing the meniscus lens to the biconvex lens. This is the right answer. We mentioned before that the best form lens, it is the meniscus lens. This meniscus lens will be the highest lens that will decrease the aberrations, either the spherical or chromatic aberrations. And this is the commonest lens used in practice and in cameras and any optical devices. But what happens if we change it to biconvex lens? This will result in increasing aberrations, and the glasses will be very troublesome and very annoying to the patient. Giving the full cylindrical correction to a pseudofake have no problem at all. That the pseudofake can tolerate it with no problem at all, and this is the pseudofake patient can tolerate without any problem. Leaving the cylindrical axis unchanged if there has been a 10-degree shift, well, this is not an indication for spectacle correction or spectacle change, meaning that if the patient is happy with his glasses and there is no complaint and there is no visual complaint of the patient, just leave it. Just leave the axis as it is. We don't change the axis unless if there is complaint from the patient. And also, the cylindrical axis will be a problem, or changing the cylindrical axis will be a problem with higher errors of refraction, like more than -3 or -4. But for smaller degrees of cylinder, like 0.5 or 1 diopter, then the change will not be will not cause any problem for the patient. And also that the shift is not 10 degrees, it can be more than 15 or 20 degrees, then these will be the noticeable by the patient. So you got it? It depends on the complaint of the patient, depends on the error of refraction, and depends on the degree of shift. All these combined together will tell you whether the patient with astigmatism, and also it will depend on the age of the patient. Those who have a younger age will tolerate the slender more, cylindrical power more, and the slight changes will tolerate it more. But for older age group, you need to undercorrect and or the slender, and also to try to be as strict with the axis as possible. Finally, under correction of the reading aid in both eyes. So under correction of the reading aid, it will not cause spectacle intolerance. Spectacle intolerance means that the patient is annoyed from the spectacle. It causes eye strain. The under correction of the reading makes the patient unable to read well at the regular distance, and he will just take the book further away in order to read, but it will not make him intolerant to the glasses. It will not make him unable to accept the glasses. But it is the reverse is the true, meaning that overcorrection of the reading in both eyes will cause spectacle intolerance. And why is that? We mentioned that before, that if the patient is having overcorrection for the reading, then this patient will have he will not use his reserve accommodation, and this will result in lack of stimulation of accommodation convergence reflex. So the patient will not converge, leading to convergence insufficiency. And so when the patient is reading a near target or reading a book, his eyes will not converge, making him suffer from eye strain. And this what will make him unable to accept the glasses or spectacle intolerance. Not the undercorrection, but the overcorrection. So I guess that almost all of you got it right. And oh, Dr. Roxana on the first place. Dr. Roxana on the fire for the first time. Well done. And let's see the explanations. We said that there are different forms of lenses like biconvex, biconcave, plano-concave, plano-convex, and the meniscus. The best form lens will be the meniscus to eliminate the aberrations. So some advices to avoid intolerance of the glasses. First of all, don't change the axis of cylinder, especially in myopes, unless there are some reasons to do so. So if you just give glasses for a patient, especially who are myopes, and you find that the autoref showing change of the axis, just don't change the axis of his regular glasses as long as he is happy with it. There is no need for a change without a complaint. Don't change the lens form worn by a myope. When you are prescribing a large cylinder for a patient who never worn a cylindrical correction before, make them into steps or gradually. The exception are the pseudo-fakes who can tolerate full astigmatic correction. Don't overcorrect hypermetrope, as it is better to leave them about 0.25 diopter sphere in order to see well for the far distance. And don't fully correct the myope in order not to make them use their accommodation, leading to eye strain. And don't give too great reading aid or overcorrection of reading, as the patient cannot read the newspaper held at his arm length, and the other reason that I told you to avoid convergence insufficiency. Don't recommend bifocals or progressive lenses without carefully considering the needs occupation of the patient, and discuss the patient, the subjective and the practical points relevant to new subscription. And don't change a satisfactory prescription unless there is a very good reason to do so. And don't advise the patient to buy new glasses for minor changes of prescription. This is very important. So I hope that this practical, important tips. Yes.
The program by me working not. I have all my points lost. It says zero by me.
Excuse me, who is talking?
Aliya Al Mukhtar.
Dr. Alia, you want to join again?
Yeah.
Okay, no problem. So
I cannot answer the last question.
Okay, so I'm giving you the option to enter again, but unfortunately, your score for the past questions will not be counted because since you are disconnected, you have to start from the start. The program doesn't have a memory for the previous users of the game.
Okay, can problem.
So I give you or I sent you the game pin in the chat. And sorry for your loss.
Yeah, yes, I hope yes work.
Okay, thank you.
Zero, our phone zero.
Okay, so let's continue. This is not the. Okay, so I guess that this is shouldn't be here. But anyway, where is the scissoring movement happens? Can anyone tell me? Scissoring movement in the retinoscopy. Where does it happen?
Keratoconus.
Yes, exactly. So I guess now you know the answer for this question. So keratoconus, exactly, it will cause scissoring movement during the retinoscopy. This is the correct answer. So Dr. Roxana, Dr. Sindhu, Dr. Alia coming to third place. And here is scissoring movement. Okay, let's move to the next question. Okay. So actually, the first and the second options are very confusing. Let me ask you, I'm aware that there are some texts that say that zero point 0.5 diopters change in the sphere can improve or worsen the vision by one strand line. But can you tell me, for those who are choosing the first option, why the second option is wrong? Well, I am just only.
Is it necessary to change the spherical power also if the cylinder power is changed? Except when you transpose it, it happens.
Can you repeat the answer, Dr. Sindhu?
Because I am confused, because is it necessary that we should change the spherical power? We have patients who come with just the cylinder power has this
Yes,
small change.
yes, it is. It is should because
When we transpose it, it will change.
yes,
So,
you will change the spherical equivalent. So the principle of the cross cylinder will not be valid. So
okay.
you have to
So
change
it's
the.
better. Okay.
This is a mandatory step in the spheric in the doing the cross cylinder. So let me tell you that I have made or I have set for the refraction test in my Royal College exam, and
Yeah.
this step is crucial in as the examiner is looking for you and he is inspecting you when doing the cross cylinder in order to see if you are going to compensate for the cylindrical change or not. Because if you didn't compensate for the cylindrical change, those who don't do this, they fail. Because
Okay.
this is not negotiable. This is very important. But my theory for the first option is, so I go with the option B based on the practice and based also on the text. But my theory that option A is wrong because from practice, zero point 0.5 diopter doesn't change the sphere or doesn't worsen or improve the vision in all patients, meaning that it can improve or worsen the vision in patients with myopia. But for patients with hyperopia, with good distant visual acuity, when you change zero point 0.5 diopter, it is not always they show decrease or increase in the potential visual acuity. I guess that all of you who are practicing agree with me on this, that not all
Yes.
hypo will show this striking changes in the vision with the changing of the refraction. So I guess that this is the explanation for why A is not right and B is totally correct, because this should be considered. If the cylindrical power is changed, the spherical power should be also changed, otherwise your refraction will not be correct. The cylinder power should be checked before the sphere. No, spherical verification should, or sphere adjustment should be done before the cylinder. And when we are checking the cylinder, then the axis is before the power. Remember, A comes before P in the alphabet. So axis is before the power. Okay, so Dr. Nahal, I'm totally with you that this is the right answer. And let's see the explanation. When you are doing the subjective refraction, there is a lecture for the total refraction process, starting from history taking to the muscle balance and the near add. I will send it to you, so you can also take a good idea about the refraction process, starting from history taking and measuring the IPD, then the retinoscopy process, followed by the cross cylinder and measuring the muscle balance and doing the heterophoria tests and the near edge. So it will be like a systematic review for refraction process. I use to give this lecture for those who are sitting for refraction test, but it will be useful for you too. So starting from the subjective refraction, when we are doing the subjective refraction, we measure for each eye separately. So for the right eye, we check the sphere for the right eye, then the sphere for left eye, then we check the cylinder for right eye, then we check the cylinder for left eye, starting by the axis and the power, and then we recheck the sphere. This is very, very, very important, because the first sphere is now changed by changing the cylinder as you change the spherical equivalent. So you need to recheck the sphere. After this, you do the duochrome test to make sure that the patient is not overcorrected. Then do the binocular balance test, near adds, and final prescription. So the sphere refinement in the start of subjective refraction is done by plus 0.25 diopter. So you offer them to the patient. If the patient see immediately better, then you leave it, and then again add 0.25 and repeat the same process. If the patient report that the vision is the same, again you leave it. If the patient report that the vision is worse, you leave it and you put minus 0.25. If you put the minus 0.25 and the patient reports that the vision is immediately better, this is important, that the patient reports that it is immediately better, then you should leave it. But if it is the same or the worse, then you remove it in order not to make the patient over minus. So this is the sphere refinement, which occurs before the cylinder. And for the cylinder, you do the cross cylinder, and we mentioned that if there is astigmatism, the patient astigmatism should be corrected in the order of axis first, followed by the power. And also we mentioned before that if we are changing the cylinder, if for each minus 0.5 diopter change in the cylinder, we need to add plus 0.25 diopter sphere, so that we keep the circle of least confusion on the retina. Because if we didn't do the spherical compensation, then the circle of least confusion will not be on the retina and the refraction of the patient will not be correct. So instead of having this example, if we add minus 0.5 diopter to the cylinder, so it will not be one diopter sphere minus 0.25 cylinder, but we should add plus 0.25 diopter to the sphere, so it will be minus 0.75 diopter sphere. This is very important. Okay, let's move to the next question. Okay, so would you please tell me why you, for those who are saying it is C, why do you think C is the right answer? Why the Snellen acuity is measured at 6 meters and the logmar at 4 meters? So I guess that some of you or some of us who are starting their practice, we use to measure the Snellen visual acuity at only 3 meters with a mirror behind us. So the mirror will make the distance like 6 meters. We like in our clinics doesn't have always to be 6 meters. They can be at 3 meters, and we with a mirror showing the behind our head in order to for the patient to see the Snellen optotype. And also the new projectors, they can adjust the size of the optotype according to the distance, whether the distance is 2 meters, 3 meters, 4 meters, 5 meters. They can still adjust the size of the optotype depending on how much or what is the distance between the patient and the chart. So it is not mandatory for the patient to sit at the 6 meter. It is not a must. But actually, the tested chart luminance should be greater than 80 candela per meter square. This is the correct answer. For the one who said that the patient with amblyopia should have the fellow eye fog, do not occluded, what is the purpose of fogging? The purpose of fogging is to prevent accommodation. So those who have myopia, amblyopia may not accommodate well, but the problem, or we should go for fogging in patients with high tendency for accommodation, like those who have myopia. So those who have myopia can sometimes accommodate at the occluder. For those patients, it is better to do fogging. So it is for myopia, not for amblyopia. So let's see who got it right. Nobody. So let's see. I'm going to present you what is the characteristics for the tested chart. The tested chart or the visual acuity tested chart has certain characters. That first of all, the stimuli or the optotypes should be of high contrast, and we said that in the basic sciences revision. So the letters should be black, jet black, against white background. So it should be black and white letters, because we are not measuring the contrast, we are measuring the visual acuity. So the visual acuity is better to be measured with the highest contrast possible. The luminance should be 85 to 100 candelas per meter square. This is the standard illumination of the tested chart. Okay, so again, the tested chart luminance should be greater than 80, as the question is saying, because it is typically 85 to 105 candelas per meter square with the contrast of 98% to 100%. So I guess that this is clear now. Can anyone tell me for your options or for your answers, for those who answered Snellen acuity must be measured at 6 meters and logmar at 4 meters, what is the logic behind this, or why did you choose this answer? Let's have some discussion about it. Anyone want to speak?
To be honest, I forgot the luminance. So what I knew was only this. The other two I knew was wrong.
Yeah, I agree with you that this is a difficult question. Me neither. I didn't know this piece of information. I haven't read it before, but when I looked for it, I found that this is a standard for this test acuity chart.
Okay.
Okay, thank you. Okay, let's move to the next question. And again, be careful from this question. It is tricky again. Okay, so as I expected that you are confused between the two options of A and D. So let's me first exclude the easy options and come to the confusing options. The acceptable technique to ensure a myopic patient hasn't been overcorrected when viewing binocularly. So the patient is now looking by both of his both eyes, and we wanted to know that the patient is not overcorrected. And what is the easy way or the acceptable way to do this is to check if the patient is accommodating or not. Because if the patient is overcorrected or over minus, he will use his accommodation to overcome this high minus. And this can lead to that the patient still can see 6.6, but he is using 6, but he is reaching 6.6 by actually by his accommodation. He is trying to overcome the over minus that you put in front of his eyes. So how can we reveal this mystery? How can we detect this over accommodation? Can this be done by checking the vision binocularly to ensure the absence of diplopia? No, this is not a test for diplopia. Don't confuse diplopia with binocularity, because the test we are speaking about is done binocular, as the accommodation is always a bilateral reflex. So don't. This is not the right answer, and diplopia has nothing to do with the patient is over accommodating or not. Then option D, double check with the power of the cylinder with a Jacksonian cross cylinder. Again, the power of the cylinder has no relation to the over accommodation. So we have two options that looks like the same, but with a slight trick. The test that is used to ensure that the patient, or specifically the myopic patient, is not over accommodating is called the +1 blur test. It is called the +1 blur test. What is the idea of this +1 blur test? The idea is very simple. If the patient has right refraction or correct refraction and he can see 6.6, what will happen if you put a +1 in front of his eyes? This will change the vision. This will make the image blurred if he has the right refraction and he can see 6.6. But what will happen if the patient is C66, but with his accommodation overcome the minus, or he is trying to overcome the over minus by his accommodation? What will happen in this case is that you are putting the +1 diopter and he can still see 6.6. He can still see good vision. So again, to differentiate, or the use of the +1 diopter test is to make sure that the patient is not over accommodating. How to know this? If the patient has the correct refraction with the correct minus in front of his eyes, and you put +1, like for example, if the patient has -4, and this is the right refraction for him, he is not over accommodating, and you put now +1, what will be the net result? It will be -3. And this -3 is not the correct refraction for him. But so this will lead to blurring of the vision. The patient will say that I can't see very well, or the vision will drop from 6.6 to 6.12. But what happens if the patient is over minused, is over corrected? Then, like for example, if he has -5 instead of -4, he can still over accommodate in order to overcome this -5, and he still can see 6.6. But when you put the +1 diopter blur test, this will result in that he will become -4, which is the right or the correct refraction for him. So he will still be able to see 6.6, although you put the +1 in front of his eyes. And this is called the +1 blur check. So what will be the right answer now? Add the +1 diopter and ensure that the vision is unchanged. Yes, this is correct. We wanted to make sure that the vision is unchanged, which will detect if the patient is overcorrecting or not. But put +1 over one eye and check if +0.25 blur the eye being tested. No, we just put the +1 diopter and check if this +1 will blur the eye. This +1 is the responsible for blurring. It is called the +1 blur test. But what happens if the patient is blurred after +1? Then this is the right reflection. But if it is unchanged, if it is the same, if it is 6, then the patient is overcorrected. And what will we do next? We just put plus 0.25 in order to reach the best correction for the patient. So the plus 25 will not blur the eye. The plus 0.25 will return the patient to the normal refraction without over accommodation or without over minus. You got it? So every lens of those have a specific function. +1 diopter for blurring, plus 0.25 to compensate for the over minus. And this plus 0.25 will make the vision more better. So I hope that this is clear, and let's show who got the right answer. Okay, Dr. Nahal and Dr. Hagar, and let's see the explanation. So what is the blur test? The +1 diopter blur test is performed at the end of subjective refraction to determine if a young patient with accommodative capacity has been over-minused or under-plussed, meaning that he is accommodating. So the blur test is usually performed after the best vision sphere subjective refraction is made. How can we do this? By placing a +1 diopter sphere lens over the best visual sphere of the eye. So let's, as we mentioned, if the patient is -4, we put a +1 over the -4. If the original visual acuity is 6.6, it should be reduced by 2 lines to about 6.12, as he is now -3. But if the vision is better than 6.12, like if he is still 6.6 or still 6.9 with the blur lens, then this suggests that the patient is over-minused or accommodating. Then what we will do next is spherical refinement, again by plus or minus 0.25 until we reach the best visual sphere. So let's have an example. A patient has right eye of -4 diopter, -2 slender, and visual acuity is 6.6. And the left eye has -5 diopter, -1 slender, and again visual acuity is 6.6. Now we occlude the left eye, and we may want to make sure that the right eye is not over-minused. So what we will do, we put the +1 diopter sphere in front of the right eye. Then the visual acuity should drop to 6.12. This means that the patient's refraction is right or correct. But if the visual acuity is better than 6.12, then the myopia is overcorrected. What will we do is we recheck the spherical correction, and it should be less than -4, because -4 here is overcorrected. We got it? It is clear now? Okay, so again, we continue our journey with the tricky questions with the next one. Exactly. So I'm glad that all of you got it right. I was expecting that we will go through a larger debate, but luckily for me and for you, we will not go through this. Okay, so when performing the cycloplegic retinoscopy, which one of the following statements is most likely to be true? Wider streak in a hypermetrope indicates that you are near the end point. Well, this is the rule for myopia or hypermetropia, that there are some clues that you are near the end point. For example, that the red reflex become more bright, become more wide, become more fast. Again, more bright, more wide, more fast. Then this indicates that you are close to the near point. It is usually performed at the 90 degrees and the 180 degrees. So this can be sometimes maybe thought that it is true that we are scooping or um, we are screening the principal meridians 190 and 90 and 180. But actually, in the practice, we don't do this. We just rotate the retinoscopy until we find a break. If we find a break, then this is the axis that we start with. So this doesn't have to be always the rule, but I'm just objecting to present the question or the answer this way because this is not totally wrong. But the option A is more correct. So this is like the trend of the ICO these days to bring you many correct answers and ask you to choose what is the most correct, of course, within the perspective of the ICO. The patient should fixate on an O at the Snellen chart. This is not wrong. This is not true because the patient is cycloplegic. The patient is now undergoing cycloplegic refraction. So no need for fixation at a distant target at all. We should compensate for accommodation by placing minus 2 diopters in the trial frame. No, we should compensate for the working distance. If it is 50 centimeters, then we will compensate by minus 2 diopters, or by putting plus 2 diopters, or subtracting 2 diopters after the end of refraction. But this is when we're doing cycloplegic refraction, there are some factors that we should take in mind. That first of all, what is the ciliary muscle tone? We should compensate for the ciliary muscle tone, which will be like between 0.75 diopters to 1.25. Depending on if the patient is hypermetrope, he will have more powerful ciliary muscle tone, and if he has myope, it will be less powerful. And also, after compensation for the ciliary muscle tone and for the working distance, what the refraction that you got is the same as after autoref of cycloplegic refraction. So again, after cycloplegic retinoscopy, after compensation of the working distance and the ciliary muscle tone, the net result will be the same as if you do autoref for patient after cycloplegic eye drops. So how much will you give for this patient? It depends on the patient's age, it depends on the patient's complaint. For example, if he has a cumulative esotropia, he will take the full cycloplegic refraction. If he is, for example, myopia, we could add like minus 0.5 to the cycloplegic refraction. If he is hypermetropia without esotropia, we can just give half of the difference between the cyclo and the non-cycloplegic refraction. So there is no fixed rule here. It is not we should compensate for accommodation by placing minus 2 diopters in the trial frame. This is not true. We just compensate for working distance. This is the correct answer. Okay. So Dr. Roxana again in the first place, Dr. Sendo in the second place, Dr. Alia is struggling to reach her place again. So we mentioned that the brightness and the speed of the reflex is what will make us believe how did we reach the neutralization point. So a reflex, when it is becoming wider and more bright and more fast, then this means that we are approaching the neutral point. So we are doing retinoscopy, and after subtraction of the working distance, and we have now this power cross. So how can we reach the refraction or the subjective refraction from this power cross? Exactly. So you got it right, and let me explain to you. I don't have the cross, so I will draw it, no problem. So we have a power cross. It is mentioned that on the when you are scooping the vertical meridian, it was +3, and when you scoop the horizontal meridian, it was +5. So how can we get, and this is after subtraction of the working distance. So how can we get the subjective refraction from this power cross? It's simple by taking any measure as a sphere. For example, we take the +3 as a sphere, so it will be +3. The difference between both measures will be the cylinder. So +5 minus 3, it will be +2. And we take the measure, or we take the axis of the first measure, or for the sphere measure, it will be 90. It will be present at the axis 90. So it will be 90. So this will be the right answer. We can make it the other way around, or we do taking the +5 as a sphere. So it will be +5. And the difference between the second measure minus the first measure would be the sphere, the cylinder. So +3 minus 5, it will be -2. And we take the axis of the first measure as the new axis. So it will be the 180. So any one of these two measures will be the correct answer. So here we present with this formula, and this will be the right answer. So if you check that, you will find that this one is like this one, but it is just a simple transposition. So both are the same thing. Okay. Okay, so let's now move to the final question of today's session, and who got it right? Okay, Dr. Roxana, followed by Dr. Sindhu, Dr. Nahal, and let's now see the last question. Exactly, so most all of you got it right. Regarding the duochrome test, if we are just making the patient see the duochrome test who is hypermetrope without any correction, without any plus or minus lens, what will be the result? That he will see the green letters more clearly. It can be used for patients who are red-green blind, because their red-green blindness doesn't invalidate the test, because it doesn't test the patient's color vision, doesn't test the patient's ability to discriminate the colors, but it will just test the ability of the patient to appreciate the color, or to appreciate the brightness of the color itself, not to name the color. It is sensitive to refraction of 0.5 diopters or more, because it can be sensitive to 0.25 diopters. And finally, overcorrecting myopes make them see the letters of green more clearly, not the red. So our target is to make the patients see the red, both of them like the same for myopia, or the red to be slightly better. Dr. Ahmed Ali, you wanted to add something? I will unmute your mic.
Doctor, can you repeat, please, what we can do in red-green color blindness
Okay.
with this test?
This test, if the patient, if you present this test in front of the patient and the patient, you ask them to compare in the brightness between the right rank and the left rank, or between the upper rank and low rank. It doesn't need, or the patient doesn't need to see the red as we see it red, or doesn't need to see the green as we see it green. He can see them with different colors, no problem at all, but he can still appreciate what is the brightness of the letters in each rank, which is more bright, the right rank or the left, or the
Yeah.
upper or the lower.
So I will ask him about the ranks only, not the colors,
Yes,
as we do always.
yes, exactly.
Thank you, doctor.
No problem at all. So here we can see that this is the optical principle of the duochrome test based on the chromatic dispersion. So the blue color and the green color have higher energy, so they are refracted more in front of the retina, while the red colors have longer wavelength and shorter energy, or less energy, so they are refracted away from the retina or behind the retina. That's why when we have a patient who is myope, he will see the red better because the eye is large. So the red color will be in focus. And also the hypermetrope, the uncorrected hypermetrope, will see the green better because his eyes now is considered as a small eyes. So the green color will be more in focus. So this is how the color blindness, or sorry, the color appreciation works. It will be just by comparing the colors, not by mentioning the names of the color. No need to know the name of the color, but he just need to know if the color is brighter than the other or not. Okay, Dr. Ahmed, I will give you the mic.
Sorry, doctor, but again, when I do a good glasses to the patient, he will see red color and the green color as same.
Yes, he should see both of them as same or slightly the red better.
Or slightly the red better.
Yeah.
And this be corrected good, no problem with him.
Yes, this is our target from refraction, from the duochrome test, to see both the same or the red better.
I ask this question because the measurement for LASIK, it is more important for us.
Yes, of course. It is very important for those who are who will undergo refractive surgery to make them not over minused, because this will result in that the patient after refraction will be high on the hyperopic side, or
Yes.
plus 0.25 or plus 0.5, making them use their accommodation and making them complaining after this from near vision.
Thank you, doctor.
Thank you very much. Okay, so this is the end of our session today, and let's see who are our winners for this session. So as a slight reminder of our prizes, we said that the third winner will have a coupon of $25 discount. The second winner will have a $50 coupon of discount of any course, and the first winner will have a $75 discount of any course with the terms and the conditions apply. And here, let's see who are our winners today. Dr. This is strange. Dr. Sendo in the second place, and for the first place, it is Dr. Roxana. Congratulations all, and hard luck for Dr. Alia. For here is the runners up, Dr. Ali and Dr. Hagar. You did great job, and sorry for your lost connection, Dr. Alia. Maybe you compensate it for the third session tomorrow. Thank you everyone for your participation tonight. It was a really tough and a really challenging session with some really debatable questions. But I hope that this question is becoming more clear now. And if you still feel any confusion, or if you had got any idea or about any question that is more with or even against what we meant to discuss today, please feel free to say in the group. send in the WhatsApp group or send it to the email. Let's have more further discussion, and if you have any enlightenment by any further reading from your text or from your practice in the MCQs, we can still rediscuss these questions and say what are our opinions about it. Because as you can see, that the ICO is more prone toward the confusing question that could have more than one possibility, and this what makes the questions are more tough and more confusing. So thank you very much again, and I wish you all the good night, and see you tomorrow for the last 20 questions of the exam. Good night.